Welcome to Medical Logistics 101, Overview of Asthma. This video is for educational purposes only. It is not medical advice, does not replace a medical evaluation, and may not apply to your situation. If you have symptoms or concerns, please speak with a licensed healthcare professional. My goal is to help patients enter healthcare with a map instead of a blindfold, and to explain how clinicians think through these problems in resource-limited settings. Definition: chronic inflammatory airway disease with variable, reversible airflow obstruction is characterized by bronchoconstriction, airway hyperresponsiveness, and mucus production. Signs and symptoms: typically we'll see episodic wheezing, cough, chest tightness, dyspnea, often worse with exercise, cold air exposure, allergens, viral illness, and sometimes worse at night. There is a cough variant asthma where cough is your primary presenting symptom, though they may have wheezing with it at times. Physical exam: generally we'll see prolonged expiratory phase. Diffuse wheezing may be absent in severe attacks. Tachypnea and accessory muscle use. Major red flag finding is if they have what's called silent chest and you really don't hear anything on auscultation, you're not hearing wheezing, you're not really hearing breath sounds at all. It's just the obstruction is so severe that they're not moving air at all, and those people are at risk for impending respiratory failure. Diagnostic studies: peak flow reduced from personal best. Spirometry, I don't really necessarily use this in the acute setting. It may be something to do potentially when I'm considering discharging that patient. But with spirometry, you would see decreased FEV1 and FEV1 FVC ratio. This is just an airflow pattern that's seen with obstructive airway disease. Pulse oximetry, this is of course is on room air, but normal or mildly low usually. It's severe if they're less than 92% on room air. Chest x-ray, again, usually going to be normal with asthmatic uh, exacerbations. I'm mainly looking for other potential causes when I do the chest x-ray, such as pneumonia. Consider if there's fever, focal findings, or atypical symptoms. I always get a chest x-ray on these patients, but again, I'm not really looking for proof that it's their asthma. I'm looking for other possible causes that I don't want to miss. Differential mimics, COPD, of course. Congestive heart failure, in this case it would be pulmonary edema. Going to have kind of a different exam and presentation. Generally going to hear crackles from the fluid in their lungs, and they're going to give you a history typically of laying, if it's worse when they're laying flat. Just kind of have a different, may have peripheral edema at the ankles in particular. And oftentimes they will give you a history of congestive failure, but certainly I've seen patients that have both congestive heart failure and asthma. Pneumonia, of course, would be in our differential. Always, of course, pulmonary embolism, which, if you think about it, pulmonary embolism can produce a lot of the same symptoms as an asthma attack. Sudden onset certainly can produce hypoxia. So, yes, it's one that you have to have in the back of your mind. Anaphylaxis certainly can produce airway obstruction for sure. Hopefully, in these patients, you would hope to see other signs such as facial swelling, rashes, things of that nature. But yes, anaphylaxis can certainly produce airway obstruction. Bronchitis, viral bronchitis, uh, particularly a problem in people that already have underlying asthma and they get viral bronchitis on top of it. Red flags: inability to speak full sentences, accessory muscle use, especially in children, silent chest, again, major red flag where there's not moving air at all, altered mental status, peak flow less than 40% of predicted, oxygen saturation less than 90%, 92% on room air was a red flag. Of course, cyanosis would obviously be a red flag. And a big one is history of ICU or intubations in the past for asthma attacks. That's kind of a clue that that person's obviously prone to becoming severe. Pitfalls: assuming wheezing equals asthma. As I said, it can be other causes such as congestive heart failure, anaphylaxis, or any sort of obstruction. And I would add with obstruction, always be on guard against, especially pediatric patients, the possibility of aspiration of a foreign body, like a peanut or something similar, that might not be radiopaque on x-ray. Miss pneumonia, of course, would be something you'd have to think about. Underestimating severity when the wheezing disappears. I tend to watch these people for a period, even though they have had improvement. I still want to watch them, and it gives time for, if I've given them steroids, and I generally do, time for the steroids to have an onset of action. So I typically will observe these people for a period of time. Not starting steroids immediately. Of course, my first treatment is the breathing treatment, but steroids are right after that, generally speaking. Check for triggers in the history, such as viral, allergen, or smoke exposure that may have played a role. Over-reliance on normal vitals early in an exacerbation. Again, they need to be observed. Disposition: home generally if you're improved with bronchodilator, vitals are stable, and they have good peak flow and reliable follow-up. I would say ED observation for moderate or severe symptoms, poor response, or any red flags. Uh, And last, I would say admit if there's persistent hypoxia, you've had to do repeated treatments, there's a history of severe disease in the past, or past admissions for asthma. Of course, ICU for a pending respiratory failure. In closing, if this is the kind of content you find helpful, please like and subscribe. If there are topics you would like to see covered, you can email me at medicallogistics101@gmail.com. Remember, the danger isn't always what you know, but rather what you can't afford to miss. Thank you.